All right, so my name is Dr. Rochelle Blackman, and I am a hematologist currently working in Halifax, Nova Scotia with the Dalhousie University Group. And I'm very happy to have been asked to present today. So the topic we'll be talking about is pregnancy in women with bleeding disorders, what to expect when you're expecting or considering pregnancy. See if I can get something in here. So I don't have any specific disclosures other than to say that I do have a significant interest in treating women with bleeding disorders. And I do work here at our adult bleeding disorders clinic, and I was in New Brunswick prior to, and I'm very excited to go and do more training in the US in this specific topic. And I'm very excited to bring that back to Canada when that's all done. So for today, we are going to talk very briefly, because we only have so much time, about bleeding disorders in general, specifically how do these present in women, and in terms of pregnancy, who are the important people in the healthcare team that will take care of individuals with bleeding disorders during their pregnancy. And then we'll talk about some tidbits of information that's helpful when you're expecting or prior to when you're considering pregnancy. What are some things to think about during delivery and afterwards, and some expectations for baby. And why does this matter? So as a whole, there has been a big push from the bleeding community to try to improve the amount of information as well as help for women with bleeding disorders, especially around the time of pregnancy and delivery, because we do know that they can experience complications, and we're trying to improve that overall. And a big part of that is going right to the source. So we're trying to empower women with bleeding disorders themselves to help navigate this medical system, trying to give you good ideas of what are questions to ask, who to look for, and when to ask for help. So bleeding disorders in a nutshell, there are many. Our bodies regulate bleeding and clotting in a very complicated system, and bleeding disorders can happen when there's either a low amount or poor functioning of any of the factors along these pathways. And this can happen out of the blue, but they usually always happen in relation to some kind of genetic mutation that can either happen randomly, as mentioned, or be passed along in families, or we describe that as being inherited. How can these present? So specifically in women, it can be with easy bruising or very big or painful bruises with very minimal to no trauma, bleeding, and that can be either gum bleeding, gastrointestinal bleeding, urinary bleeding, or nosebleeds. Just a mention on periods. So, we always talk about what's a normal period. And if you've had the same period all your life, you may think that that's normal. But what we talk about in terms of heavy periods that is not, air quotes, normal, or menorrhagia is the word that we use, is when periods last longer than 7 days, and changing pads or tampons every 1 to 2 hours. And certainly women with bleeding disorders can have very large clots, can have a lot of cramping, and have a lot of issues with this in particular. In terms of bleeding during pregnancy, that may not necessarily be a significant issue with women with bleeding disorders, but certainly bleeding after pregnancy. So postpartum hemorrhage, and we'll talk about that, is something that can become quite an issue in terms of managing this appropriately. Rarely in some of the more rare bleeding disorders, we can see women having issues with recurrent pregnancy losses, so something to keep in mind. And then we can see bleeding to muscles and joints and after surgeries. I put a little note here about iron deficiency. So since we bleed every month, we also lose our iron along the way, and iron deficiency anemia is something that can happen quite often and silently for a very long time. So I just mentioned that here in this kind of list. And then, we did talk about these are things that are often passed along in families. And so there's often this story that, oh yes, all of my moms and sisters had very heavy periods and everyone had hysterectomies. Or there can be a different story where a lot of the males in the family, and we'll talk about when that might pop up, have had issues with bleeding in ankles and elbows, and maybe not necessarily so much in the woman herself. And this is important because we need to normalize talking about our periods. We need to normalize opening that conversation with other healthcare workers. And I just put this in here. There's lots of great other videos on this website and lots of tools to help us understand when we have periods that are out of normal, what to do. And this is just something that's on the National Hemophilia Foundation website that I put here. Just again to say that, you know, knowledge is power, and a lot of this needs to come from ourselves. And so just to kind of put this here as a reference for you. Very broadly, so here are kind of schematically our bleeding disorders. The ones that you may have heard of more often would be hemophilia A and B. So these are two bleeding disorders that are passed along what we call an X-linked recessive fashion. And we'll talk about what that means. So on our X chromosomes, and are associated with low coagulation factors, so either 8 or 9. More commonly seen would be von Willebrand's disease, and that can be either a type 1 or a type 3. And these two are seen when there's low amounts of this von Willebrand protein that helps us regulate our clotting system. And then there's a type 2 where the protein itself is there, but the function is not normal. This one is maybe seen a bit more in terms of women, especially with heavy menstrual bleeding, but all of them can present like that. Now I have a catch-all group here that we can term the ultra rare bleeding disorders. So those are, you know, seen more in 1 in 200,000 or so of people. And it's basically low levels of all the other factors that we have. And these can be very variable in how they present. They are a lot more rare, so sometimes harder to pick up. And their genetics and how they are passed along can be a little bit different. Now I put platelet disorders here. This is a kind of a different pathway that we think about, but a lot of these can be passed along in families and can also be associated with either low amounts or low function of these platelets. So I put them here as a group, obviously not going into significant detail, but just so we kind of know that this talk can, you know, hopefully ring true for many individuals who are looking for help in this category. So just a word on hemophilia in females, and I know there are some other talks on here too about this, but as mentioned, so hemophilia A and B are both X-linked inherited bleeding disorders, and this is associated with low levels of this factor, usually under 40%. And severity is associated with how low, basically how low can you go in terms of the factor levels. And it is more commonly affected in males, and we'll talk about why that is. But I'm putting this here because, again, there's been a really big push to realize that women who have genetic mutations, in keeping with hemophilia gene mutations, often were previously thought to just, air quotes, just be carriers, and that they weren't actually affected, but that's not been shown to be true. And actually, women, even with normal factor levels, have increased rates of bleeding and morbidity. So basically that means complications than those who do not have this. And it's been felt even the way that we describe these women. So it's females with hemophilia, if they also have factors level less than 40%, or what we call symptomatic carriers, where their levels are normal, but they still have bleeding. And that's really important because a normal factor level does not rule in or out having a hemophilia gene mutation. And I think that's something that people are just kind of realizing recently. And then we describe hemophilia carriers who are asymptomatic, as in they don't have increased bleeding. But we should be thinking hard about all of these folks, especially in the setting of pregnancy. And that's kind of been a shift that we've been waiting for recently and hope to keep going. I also just make a note here that in terms of, given this is an inherited, passed along inherited bleeding disorder, typically the severity of how bad people bleed is very common throughout families. So If the, one family member is a severe bleeder, likely the next baby or the next one affected will also be severe. And it's just something to kind of be aware of. I'd put a plug here just for von Willebrand's disease. It is more common than we think. And it can go a little bit under the radar. Again, we talk about our periods being normal, and if our mom's periods are the same and our sister's periods are the same, we don't necessarily realize that what's happening on our monthly basis is actually not what we would expect in terms of periods. And often bleeding after pregnancy, so what we call postpartum hemorrhage, can be the first time where people start to notice that there may be some increased bleeding in these women, and it can go a little undetected for a long time. And this is, again, just to say that there are 3 types. Type 3 is usually quite severe, where there basically is none of this little von Willebrand's factor and is treated a bit different than the others. But there can be quite a significant spectrum in terms of how women do present and bleed. So what to expect if you are a woman with a bleeding disorder considering pregnancy? And I think my take home would be number 1, that knowledge is power once again. And getting tested prior to delivery, prior to pregnancy is probably paramount. So that being genetic testing, and this can be if you are already known to have a bleeding diagnosis, or if you're a suspected bleeding disorder, or if there's a family history that's suspicious. And I won't read it out, but here is the list of, for example, hemophilia. If this is in the family, if you are a family member, that it would make sense that you may be affected with one of these mutations, we should be having genetic testing. And on the previous slide, I did mention some of the genetic mutations that we already know and what to look for. And I'd have to say it's much easier to know this beforehand to set us up for success in these conversations about what are the risks to mom and baby beforehand than after the fact. So this is just kind of my plug for early testing, and also early things like baseline factor levels. So this is all blood work and iron studies, just to know what can come down the line in terms of a plan. I mentioned here, so preconception and genetic counseling, and we'll talk about genetics and what that can possibly look like. This is one that's probably the most important and can happen through a couple of different avenues. If you have access to medical genetics, which is a whole group of medicine that does talk about these issues, as well as through your bleeding disorder clinic, or also high risk obstetrics also can have these conversations. But again, it's important to know what's the risks to mom and baby moving forward, and we'll go into that a bit more. If you have a bleeding disorder and you would like to become pregnant, please let your bleeding center know. We like to have plans for these things, and you'll see it's a bit of a process in terms of getting your whole village together to help you get through your pregnancy and delivery. And the last thing I'll mention is that if you are planning on getting pregnant and you're on birth control, and especially if this is to try to control your heavy periods, don't forget that your periods will probably come back a lot more severe than they were when you were on birth control. So having a discussion with your bleeding center or whoever is taking care of you to have a backup, for example, we can talk about it, but tranexamic acid is a medication that helps to stabilize clots and can improve our periods, is likely smart to have on hand once you come off that birth control. Okay, so getting into the nitty-gritty. So we've talked about, we should have this idea of risks to mom and baby moving forward from a genetic perspective. But to talk about that, we need to understand a bit better of how these disorders can be inherited. So in terms of an X-linked recessive, so a recessive gene means that it can be trumped by something else, okay? And I think, it's important to remember that women have 2 X chromosomes and men have 1 X and 1 Y chromosome. So both for hemophilia A and B, it means that there is one of these little genetic changes on an X chromosome. Now, I took these lovely slides mostly because they're very wordy, but it helped to explain how these things can be passed on from the Hemophilia Federation. And I won't necessarily talk about the scenario in the middle where the father has hemophilia, but it's there just for your reference point. So for example, if mom has one genetic mutation for hemophilia on her X chromosome, so one is mutated and one is normal, and she has a baby with a dad who does not have hemophilia or a mutation, as you will see, that mom will give one or the other of the X mutation to a boy. And so there's a 50% chance, because boys don't have a second X chromosome to trump that mutated X chromosome, that 50% of them will have hemophilia. Now, in females, so if the same scenario, 50% of the girls and baby girls will also have one of those mutated genes, so she would be a carrier. Now, on the flip side, if it so happened that a father with hemophilia, so that means that he has an X chromosome that is mutated, has a baby with a mom who is a carrier, then this probability is a bit different. So in males, 50% of those males will not have hemophilia, as you can see in blue there, but 50% of them will, okay? But on the flip side, it's different for the women. So 50% of the females will be carriers and 50% will have hemophilia because they will inherit two affected X chromosomes. So as you can see, it's very helpful to know prior to pregnancy, and also important to ask dad his breeding history, and sometimes also have genetic testing done to understand what is the risk to baby being born. And as it's also obvious with X-linked disorders, it matters if you are a boy or a girl in terms of your risk of having hemophilia or having hemophilia carrier status. On the flip side, so I just put this in here to understand differently. So for all the other breeding disorders that are not X-linked, so other than our X and Y chromosomes, we have two genes for everything. But in the setting of recessive and dominant mutations that can get passed along, it has nothing to do if you're a boy or a girl. So now we talk about, for example, in von Willebrand's type 1, something that's called autosomal dominant. So you can have a mutation that will trump anything else. So if it's there, it will always be what we call expressed. You'll see it. So for example, here, this autosomal dominant schematic on the left. So if one of the parents, so for example, if mom has von Willebrand's type 1 and has one autosomal dominant gene mutation and has a baby with a dad that does not, you'll see that 50% of the kids will be affected. And it doesn't matter if it's a boy or girl. On the flip side, on more commonly seen in the ultra rare bleeding disorders or the other types of von Willebrand's disease, this is actually what we call an autosomal recessive hereditary. So you need two of these little mutations to be expressed. So both mom and dad have to be either a carrier or affected. And this is different. So you'll see here that 25% will be unaffected, 25% will be actually affected, so have the true disease, and then the rest, or 50%, will be a carrier. And these are just the conversations that are had at these pre-genetic counseling to try to understand what a risk to baby. You'll see here that actually, the group of individuals who should be looking after any woman who has a bleeding disorder in pregnancy is, it's a village. So I put here in purple the bleeding specialist, so hematologist and the bleeding disorder coordinator as kind of the quarterbacks. And we should really be helping everybody else coordinate everything so that mom and baby have a safe pregnancy. But who's important? Very important are family doctors so that they can be involved and know what is happening. Specialty obstetrics. And I can't say enough how important it is for individuals who are experiencing bleeding disorders to be following this population of patients. Also anesthesiologists, the medical geneticist, if that's how genetic counseling is going to happen. And then I put here blood bank, because for individuals who do require factor replacement, we do need to have access to these therapies. And then I put pediatrician here, because at the end of the day, baby needs to be followed up if there's any concerns the baby also could have with the disorder. So what to expect when you're actually pregnant? Well, again, you should expect that there should be a collaborative discussion and plan for baby and for mom that should go over testing and how much testing should happen throughout pregnancy and afterwards, treatment options and targets, good discussions with obstetrics regarding the risks and benefits of a C-section versus what we call spontaneous vaginal delivery. Talking about anesthesia or epidurals, there's this myth that if you have a bleeding disorder, you need to have, that you can't have any pain control, and really it's more of a discussion, and it's not actually quite the case. And then to have a good plan postpartum to make sure everybody's safe, as well as for baby. And just a mention here about coagulation testing. So I've talked about how bleeding disorders are associated with low factor levels. Well, the body is actually kind of smart. And so whenever we are pregnant or in the setting of increased hormonal therapy, breastfeeding, hormonal therapy, birth control pills, or right around the time of childbirth, or even if you have vigorous enough exercise, the body actually rises in terms of its factor levels. And this is helpful, obviously, because the body knows that it might have to bleed whenever we have a baby. So we can see levels rise over pregnancy, which is quite helpful. But just to make a note that this actually is not seen in von Willebrand's types 2 and 3 or factor 9 deficiency or hemophilia B. On the flip side, though, after baby is out, even 4 hours after delivery, we see these levels plummet and can go back to baseline. And that can be for as long as up to 6 weeks afterwards. So bleeding after delivery is very important to be aware of, and should not be considered to be in the realm of normal, and also should be very clear to individuals when they go home that if they start having menstrual bleeding quite significantly, that could be an issue. So I put here, so I'm definitely not an obstetrician, but I will say, so our recommendation for testing for baby during pregnancy, number 1, if there's any concerns about hemophilia or an X-linked disorder, that ultrasounds early around week 10 or so to determine the gender of the baby is recommended, mostly because male infants, who, as we just talked about, we can most likely be affected more, especially if the bleeding type is severe, because there's an increased risk of bleeding and kind of head bleeding, actually, or intracranial bleeding, as we say. And so we need to plan for that accurately afterwards. And then, so it's probably not done very often, but every decision is individual, and I'll put that there. But sometimes there is a need to consider fetal testing for genetic markers during pregnancy. And these are done with needles that can actually be in it during different times throughout the pregnancy. So you'll see here chorionic villus sampling, amniocentesis, to do specific genetic marker testing. Now there is risks of miscarriage and there's risks of bleeding. And oftentimes now, if we can have a good idea going into this, that's not necessary. And obviously this is a discussion that is held with our high risk obstetrics team. So in a nutshell, in terms of prevention and treatment options, I've put a bunch of things here. So just to note, you may or may not have heard of these before, but DVADP is an injection that we can have under the skin. It's a hormone that helps to release some of our coagulation factors and is often used in hemophilia A or von Willebrand's disease, or sometimes platelet disorders. It is not helpful in types 2 and 3 and factor 9 disorders. And actually, in some individuals, they don't actually respond. But it is relatively safe in pregnancy. There can be an increased fluid shifts, and so obviously we try to avoid that too much, but certainly it can be used and in a setting where we're either trying to prevent or stop bleeding. Tranexamic acid, or the other name for that is cyclocapron or TXA, which is much easier to say, is a pill that can be taken and it helps to stabilize clots, and it's often used in pretty much all of our bleeding disorders. There's a very, very small risk of clots, so sometimes we might think a little bit hard about individuals with a history of clots, so the opposite of bleeding. But it's generally quite safe in pregnancy and often is also used postpartum and is quite safe in breastfeeding as well. Now, a big catch-all here is factor concentrate. So depending on your factor deficiency would inform which factor needs to be replaced. Typically, we are aiming for a target of 50%. So I told you that factor deficiencies are usually when that factor level is less than 40%. And then usually we do this around the time of delivery, absolutely. Sometimes we do have to give some throughout pregnancy, depending on levels. And I just put that here that sometimes, as I mentioned, prophylaxis just means that we give kind of lower doses throughout pregnancy from a target level. And then I put platelets and fibrinogen here. Usually those are options if people are actively bleeding or if they have platelet disorders. And then this is just another plug for iron. You know, we can either take that as a pill or IV iron, which is safe mostly in second and third trimester. We don't have as much evidence to demonstrate the safety in the first trimester, although I'm betting that we're going to go that way sometime soon. And that's just my plug as a hematologist. And this is just an app. It's called the Iron Mom app, which is really neat. That's helping to bring more information to moms in terms of iron deficiency anemia during pregnancy. And as we know, iron deficiency and heavy menstrual bleeding is really common in women with bleeding disorder. So I put this here just for your knowledge. And again, just a comment on supplementation can be done in different ways. So what to expect during delivery, and I think if anything can come from this other than getting tested, it's that the safest delivery for a baby born to a mom with a bleeding disorder is at a hospital with bleeding specialists, with access to specialized obstetricians and anesthesiologists, as well as access to the products that we just talked about, because they are not necessarily easily available at outside sites. So I just put that there as that's, you know, the most important thing. But here's just a list of things that you may or may not hear during these conversations. So things that we try to avoid is any risks to mom or baby in terms of minimizing any trauma with that delivery. And just to note that some of the factor replacements, some of them are made in a lab and some of them are collected from blood products. And there's a very small risk of plasma-derived products of an infection, something called parvo B19, which is something that can cause low hemoglobin actually from a viral infection. So probably using recombinant products in women who are pregnant makes the most sense. And then this is just a list of different things that we would ask our obstetricians to avoid. Things like metal forceps sometimes that are needed to help babies come out. Different things that we try to avoid again from any trauma. And then things to plan for. So an epidural. So that's the you know, the anesthesia that's given into our back. This can be done if factor levels are above a certain amount by an anesthesiologist who is well versed in this, and so it's not an absolute no, but something to be aware of. Discussions of the risks of C-section versus vaginal delivery. The jury is out, I said, because there are some who feel very strongly about one way or the other. There are some scenarios where obstetrics may elect to do a C-section instead of a normal vaginal delivery, mostly if a baby who may have a bleeding disorder or just in general are breech, so kind of bum first instead of head first. Or if we have concerns that there is a hemophilia male who may have a severe bleeding type, just because the risk of a brain bleed with a delivery may be slightly higher. But in general, it's a conversation to be had. And again, everyone can be a little bit different. So I just put that there, just some things to know or to think about. So what should you expect for your baby? So again, the rule of thumb is that, if we're passing along the same gene, we'd expect that baby to have the same type of bleeding as mom, or family member. But obviously, we still like to be cautious. And so number one, we do ask our pediatrician colleagues to be involved whenever babies are born. Most babies aren't going to bleed at birth, but we do monitor for any bruising. And if there's poor healing of their umbilical cord, that can be a sign that there may be some issues with the bleeding system. Brain bleeding or intracranial hemorrhage, as we say, is the bleed that we watch for the most. And there are some factor deficiencies, especially factor 7 or factor 13 deficiencies, that may be seen more often. And so these are individuals who are much more closely monitored. In terms of circumcision, that is something that we definitely would want to put off and be done by a skilled surgeon, and would want to have a good plan if that is something that is really felt strongly to be performed for baby. And this is just another note about, baby can be just as severe or less severe in terms of bleeding as a family. And that we can do testing for factor levels and things from the cord blood itself. We avoid any kind of IV pokes or intramuscular injections and things for babies that we may have some concerns about. But to be clear, that there can be some mixing of mom's blood with this. And so usually factor testing may be repeated later on. And if there isn't, an urgency, this can be even waited until about 2 years of life or longer. But just so you know that we do monitor these individuals moving forward. And then, so vitamin K is a vitamin that helps our clotting system. And usually babies actually get that as a little heel prick. But we do recommend that it be given by mouth by these little ones instead. So I made this as a timeline. So this pre-pregnancy or considering stage, if you're off your birth control, you might be having some more bleeding. This is the time to be seen by your bleeding disorder clinic, or if you haven't been assessed yet, to be asked to be referred by your family doctors or however you can. We should be having this preconception counseling. We should be checking genetic markers if we have access to this. We should be checking iron and any factor levels at baseline. And then once we become pregnant, as mentioned, there can be a small miscarriage risk, and usually that's in the first trimester. But we should be having checkups with bleeding clinic and obstetrics and whatnot. The second trimester is when, if we are going to need to doing field testing, which again is not common, but it would usually happen around this time. And we may or may not be requiring IV iron at this time. Typically somewhere between 20 to 35 weeks. I put 35 weeks because that's what I'm used to. But we do recheck these factor levels. And remember, I said that in a lot of, for example, factor 8 or von Willebrand's, these levels may come up. And this is where we're looking for a safe level to going into delivery. So it may be that if you haven't hit that 50%, we're talking about finding ways to do that with prophylaxis. We're coming up with a birth plan. We're talking to obstetrics about, is this going to be a planned C-section? Is this going to be a vaginal delivery? Talking to pediatrics, whether or not DAEP will be required. And again, IV iron can certainly be administered during this time. And then baby happens, and pediatric sees, and afterwards, as mentioned, we're watching for bleeding up to 6 weeks post. Pediatrics are doing what they need to do. And it is good that we should be rechecking your bleeding times and your factor levels and your iron afterwards. So you should be having follow-up, within the week or so afterwards, just to make sure. And before you leave hospital would be ideal, just to ensure that we're not missing anything. You may or may not need some ongoing IV iron, because if you're breastfeeding, those babes are going to take your iron as well. And then just to mention that sometimes tranexamic acid or other factor replacement is required in the postpartum time. I just took this because it probably maybe also explain things in a different way, but this is just a nice schematic of also kind of all the different things that need to be happening in just a different schematic. in terms of a good pregnancy and delivery for a mom with bleeding disorder. So I'm hoping that was helpful. These are my take-home points. No matter how you bleed, let your healthcare team know. If you aren't under the realm of a bleeding disorder clinic and you have any concerns or family history, please do advocate for yourself, as I know that you all are, in terms of being referred and getting tested as you need to and going from there. I just said get tested again before baby. Sometimes we can't plan for these things, but if we can, that would be great. And I'm again just advocating for more information for you as patients and also throughout the healthcare system, just so that everyone on the ground understands a lot more of the issues that are presented to this population. And then just what are your treatment options and what might you expect and when to ask for help. And I'm hoping that's helpful, and I wish you all the best.